Welcome back to Senior Healthty Care, where you will discover several recommendations for seniors. Today we provide essential suggestions for seniors that cannot be overlooked. Independence after 53 moves for stairs, balance, and confidence. For those aged 50 and over, the preservation and enhancement of lower body strength is crucial for sustaining independence, mobility, and safety in daily activities. The functional capacity of the legs manifested in the ability to rise from a chair, ascend stairs, ambulate with stability, and recover from disturbances without falling directly affects quality of life engagement in meaningful activities and long-term health. Despite the prevalence of age-related deterioration in skeletal muscle mass and function sarcopenia, a vast body of research and extensive clinical experience demonstrate that precisely focused exercise therapies may significantly mitigate and, in several aspects, reverse functional decline. A fundamental program to rehabilitate lower limb strength and stability does not need gym access or specific equipment. A concise, evidence-based program consisting of 3 fundamental exercises: the wall sit, calf raise, and glute bridge, with intentional core engagement executed consistently at home, may restore vital neuromuscular connections and provide significant improvements in strength control and confidence. This comprehensive guide analyzes each of the 3 movements thoroughly: physiological rationale, primary musculature and biomechanical actions, meticulous step-by-step execution, suggested training parameters, frequency sets, repetitions or durations, rest progression strategies, anticipated sensory feedback, common technical errors and corrective cues, safety considerations, and practical modifications, as well as nutritional guidance aligned with the exercise's demands. The text emphasizes neuromuscular training, which is the process by which the central nervous system enhances its capacity to recruit time and coordinate muscle fibers and groups, as neural adaptations frequently account for initial functional improvements without visible increases in muscle size. The aim is to provide older persons' caregivers and physicians with a thorough pragmatic framework for safely, gradually, and sustainably enhancing lower limb strength and stability. What is the rationale for selecting these 3 exercises? Coverage of fundamental functions. Collectively, they include knee extension and load tolerance wall, sit ankle plantar flexion balance, and venous return calf raise, as well as hip extension and lumbopelvic control glute bridge. These are the essential motions necessary for ambulation stair navigation transfers and postural stability. Limited apparatus, significant transferability. Each workout needs minimum space and basic home supports, such as a wall, robust chair step, or resistance band, yet immediately correlating to daily tasks, rising from a seated position, propelling oneself, while ambulating, sustaining an upright posture. Focus on neuromuscular control. Intentional regulated exercise with an emphasis on tactile and verbal signals enhances neural coordination, hence enhancing the timing and sequencing of muscle activation essential for safer movement. Preliminary considerations prior to commencement. Warm-up. Prior to prolonged holds or repetitions, condition the body with 5–10 minutes of modest cardiovascular exercise, marching in place, leisurely, walking soft step-ups and joint mobility exercises, ankle circles, hip swings, mild knee bends. A gradual warm-up enhances blood circulation, elevates tissue temperature, and prepares motor pathways for coordinated movement. Breathing. Inhale normally. Refrain from extended breath-holding Valsalva, particularly during isometric contractions. Diaphragmatic breathing during physical activity enhances core stability, regulates blood pressure responses, and alleviates excessive intra-abdominal pressure. Distinguishing pain from effort. Anticipate localized muscular exhaustion, a burning sensation, or minor delayed onset soreness. Nevertheless, intense radiating or joint-specific pain indicates a need to halt and reevaluate technique or see a specialist. Differentiate between safe pain muscle tiredness associated with work and indicators of tissue harm. Frequency and recuperation. Target 3-4 sessions weekly dedicated to these exercises with a minimum of 1 rest day between sessions. Sleep, diet, and stress management together facilitate tissue adaptability and neural recuperation. Baseline assessments. Document fundamental functional evaluations before to commencement, timed up and go, tug 30-second sit-to-stand count, single leg stance duration, and a timed wall sit hold to objectively track improvement. Reevaluate the program every 4 weeks for necessary adjustments. Pragmatic safety and installation recommendations. Footwear and surfaces. Utilize sturdy, non-slip footwear or engage in barefoot activity on a non-slip surface if comfortable. Refrain from standing workouts on slick floors and uneven surfaces. Environment. Maintain a clean area free of tripping hazards. Ensure the availability of a robust chair or railing for balance assistance, particularly during the acquisition of single-leg progressions. Medications and medical conditions. Recognize that antihypertensives, diuretics, or drugs impacting balance or sensation, e.g., some psychotropics or neuropathic medicines, may compromise exercise safety. Seek the counsel of a doctor for intricate medical concerns. Warm-up versus movement. Incorporate dynamic mobility in lieu of prolonged static stretches prior to workouts, since static stretching may diminish immediate force output. Reserve moderate static stretches for the cool-down phase unless instructed differently by a therapist. The wall sit, static strength and endurance for the knee and hip joints, justification and neuromuscular advantages. The wall sit is an isometric exercise in which muscles exert force without altering joint angles, enhancing sustained strength and endurance in the thigh and hip extensors, quadriceps and gluteus maximus, while engaging posterior chain and core muscles to preserve alignment. The low-impact nature is appropriate for older persons to develop muscle that supports the joints without subjecting them to recurrent high-impact stress. Besides mechanical fortification, the wall sit serves as neuromuscular re-education. The central nervous system acquires the ability to maintain coordinated activation under load-enhancing posture and balance during activities such as rising from a chair or descending stairs. Isometric training enhances the pace of force creation in functional scenarios and translates to dynamic activities when integrated with concentric and eccentric exercises. Fundamental musculature and biomechanics. Quadriceps femoris, the principal extensor of the knee-generating torque, to counteract knee flexion and regulate the body throughout transitions from sitting to standing and during descent. Gluteus maximus, a hip extensor that stabilizes the pelvis and prevents downward displacement during extended knee flexion. The hamstrings co-contract to support the knee and contribute to hip stability. Core transverse abdominis, oblique spinal erectors sustain back contact with the wall and maintain neutral spinal position. Isometric training gradually activates motor units, while others exhaust, so improving muscular endurance and neural efficiency. It also reduces tendon strain variations associated with dynamic loading. Sequential execution. 1. Position yourself with your back flush against a firm, smooth wall. Feet must be positioned shoulder-width apart and about 18 to 24 inches 45 to 60 centimeters from the wall's base. Increasing the distance of the feet enhances depth and knee flexion. 2. Gently draw the navel towards the spine to activate the deep abdominal muscles. This serves as a subtle internal signal rather than a complete breath hold. Maintain relaxed shoulders and a neutral chin. 3. Gradually descend down the wall by flexing the knees as if settling into a chair, targeting about 90 degrees at the hips and knees if comfortable. Modify the depth according to knee comfort and stability. 4. Ensure that the knees align with the ankles and should not extend far beyond the toes. The shins should remain almost vertical. When necessary, visualize applying pressure via the heels to safeguard the knees. 5. Ensure complete contact between the back and the wall from the shoulder blades to the lower back Evenly distribute weight over the foot from heel to toe and breathe consistently. 6. Maintain the location for the specified period. To conclude, exert pressure through your heels and smoothly ascend along the wall to an upright position, maintaining core engagement. Training parameters and a coherent introduction procedure. Frequency 3 to 4 times weekly, with a minimum interval of 48 hours between high-intensity workouts. Volume initiate with 3 sets of 10 to 30 seconds, contingent upon current capacity, with 30-60 seconds of rest between sets. Progression. Augment hold duration by about 5 to 10 seconds weekly until achieving 60 seconds or more each set. Once holds of 90 and 120 seconds are readily attainable, include modifications such as partial repetitions, minor pulses during the hold execution with arms crossed, or brief unsupported wall squats, provided balance and joint health allow. Alternative dosing. For those unable to maintain continuous length, execute numerous shorter holds, e.g., 6 to 10 holds of 10-15 seconds, with short intervals of rest, or cluster holds with 10-20 seconds on followed by 10-20 seconds off for a specified period. Intensity modulation. Shallow wall sits 45 dig are suitable for persons experiencing knee discomfort or in the early post-operative phase. Deeper postures enhance strength but elevate joint stress. Progress gradually. Somatosensory feedback and anticipated feelings. Normal continuous burning or tiredness in the quadriceps and gluteal muscles accompanied by a little tremor as motor units get fatigued and further units are recruited. Increased respiratory rate or temporary lightheadedness may arise if breath is retained or severe exertion is exerted. Modify breathing if seen. Warning indicators: acute anterior knee pain, paresthesia, new or exacerbated lower back pain, dizziness or chest discomfort. Cease activity and reevaluate. Obtain medical consultation for alarming symptoms. Prevalent technical faults and their resolutions. If knees extend beyond toes, adjust feet slightly backward or decrease depth to maintain vertical shins. Instruction. Position your feet posteriorly until your shins are perpendicular to the ground. Inadequate depth, gradually promote a deeper posture to engage target muscles. Starting at a 45-degree angle is okay, provided the person incrementally increases tolerance. To prevent losing back contact, maintain a small posterior pelvic tilt to keep the lower back in touch with the wall. Re-engage the core and visualize tucking the tailbone. Breath holding instruct, gradual consistent exhalations, e.g. exhale for 3 and 4 seconds during holds to prevent Valsalva maneuver and fluctuations in blood pressure. Distribute weight onto heels, apply pressure via the heels, while envisioning a tiny elevation of the toes to accentuate posterior weight allocation. Alterations and specific demographics. Decrease depth, start at a 45-degree hip angle, or execute seated isometrics if standing poses a risk. Chair-supported isometric holds. Sit on a chair and apply pressure with the knees on a rolled towel positioned between them to simulate adduction and activate the quadriceps when standing is hazardous. Uncontrolled hypertension, get medical clearance before to engaging in protracted isometric holds. Shorter repeated holds may be safer and less likely to induce hypertensive spikes. Following recent knee surgery or significant pathology, it is advisable to see a physical therapist. This may need the avoidance or replacement of exercises with aided squats, partial weight-bearing progressions, or regulated eccentric training. Balance or vestibular impairments. Execute activities within arm's reach of stable support. Contemplate sitting strength alternatives till balance improves. Dietary assistance for wall sits and endurance-based muscular activities. Electrolytes magnesium and potassium are essential for muscular contraction and neural transmission. Food supplies including bananas, sweet potatoes, avocados, cooked spinach, legumes, and nuts. Older persons taking diuretics should see a doctor about their magnesium and potassium levels. Protein. Older individuals have less anabolic reactions to protein, known as anabolic resistance. Target around 1.01. 2 g-kilos of body weight per day for typically active older persons. A greater intake of 1.2–1.5 g-kilos may be suitable in cases of injury or more rigorous exercise. Prioritize proteins rich in leucine, such as dairy eggs, lean meat, and soy, and allocate protein intake evenly between meals 22 to 40 green each meal to optimize muscle protein synthesis. Hydration. Sufficient fluid consumption enhances endurance. Modest quantities of liquids, 150–250 ml prior to workouts, might be beneficial. Observe urine pigmentation and levels of thirst. Refrain from consuming dehydrating drinks just before to physical effort. Post-exercise snack, brown rice with a scrambled egg and steamed broccoli complex carbohydrate, plus 20 to 25 gram protein, or Greek yogurt with fruit, and a handful of almonds ideally ingested within 1 to 2 hours after physical activity to facilitate recuperation. The calf raise, equilibrium thrust, and venous circulation, justification, and neuromuscular advantages. The calf muscles are often neglected in training, however they are essential for balance forward propulsion while walking and facilitating venous return from the lower extremities. Enhancing calf strength augments ankle joint mobility and proprioception, the sensory input from muscles and joints that facilitates corrective responses, thereby diminishing fall risk and enhancing walking efficiency. The calf raise enhances both concentric ascending and eccentric descending control while fostering tendon resilience, so facilitating effective push-off. Principal musculature and biomechanics. Gastrocnemius, a biarticular muscle that traverses the knee and ankle, facilitating plantar flexion and explosive propulsion, exhibits maximal activity when the knee is extended. Soleus, a deeper uniarticular muscle essential for postural stability and endurance, particularly in flexed knee situations. The plantar fascia and Achilles tendon collect and release elastic energy. Decelerating the eccentric phase enhances tendon strength and mitigates the danger of overload. Intrinsic foot muscles contribute to arch stabilization and facilitate force transfer. Sequential execution. 1. Assume an upright position with feet aligned at hip width. Use a wall or robust chair for minimal balancing assistance. Hands should provide stabilization without exerting upward force on the body. 2. Activate the core, maintain an erect posture, and direct your gaze forward. 3. Gradually apply pressure through the balls of the feet to elevate the heels as high as comfortably achievable while maintaining relaxed, unlocked knees. 4. At the apex, maintain a hold of 1 to 5 seconds. Begin with shorter durations to optimize muscle fiber activation. 5. Descend the heels in a deliberate way, waiting 2 to 4 seconds to return to the initial position. This eccentric control is crucial for tendon health. 6. Perform the specified repetitions. Advance from bilateral to unilateral exercises as balance and strength improve. Training parameters and advancements. Frequency 3 to 4 times weekly on non-consecutive days for elevated intensity workouts. Volume initiate with 2 to 3 sets of 10–20 repetitions, allowing 30–60 seconds of rest between sets. Advancement opportunities, augment repetitions or sets. Extend the eccentric lowering phase to 4 to 6 seconds to enhance stimulation. Perform single-leg calf rises to increase load and test balance. Begin with aided single-leg holds near a support. Deficit calf rises executed on the edge of a step to enhance range of motion and eccentric load. Introduce mild external resistance, such as holding a dumbbell kettlebell or carrying a weighted bag when balance and strength allow. Employ sitting calf raises with knees flexed to specifically engage the soleus when the gastrocnemius is restricted by knee positioning. Somatosensory feedback and anticipated feelings. Normal, robust contraction and temporary burning sensation in the calves, a little strain of the Achilles tendon during the lowering phase, and enhanced stability during single-leg stance or ambulation with training. Warning indicators: abrupt intense pain in the calf or Achilles tendon, acute edema, or inability to bear weight, cease activity and get medical assessment. Frequent errors and their rectifications. Employing momentum. A deliberate measured speed accentuates muscular engagement and mitigates danger. Maintain an erect trunk and activate the core to prevent transferring the workload to the hip extensors. To minimize overcompensation via knee extension, maintain mild knee flexion during bilateral rises when the objective is to primarily target the soleus. In the presence of acute Achilles, discomfort, cease activity, and seek clinical advice. Early-stage tendinopathy often improves with isometric holds followed by gradual eccentric exercises under supervision. Adjustments and specific demographics. For balance impairment or peripheral neuropathy, begin with seated calf lifts, second toe pushes, or resisted plantar flexion, or use two-hand support until stability is achieved. For recent Achilles tendinopathy or calf strain, isometric calf holds pressing into the ground without movement may be used initially to alleviate discomfort and preserve conditioning. Progressively advance to eccentric exercises. Edema and venous insufficiency calf muscle contractions enhance venous return. Integrate calf raises with elevation post-activity, use compression stockings as recommended, and seek clinical advice if edema exacerbates. Nutritional assistance for calf performance and circulatory health. Dietary nitrates from beetroot, pomegranate, and leafy greens may enhance nitric oxide pathways, possibly enhancing blood flow and exercise tolerance when ingested prior to sessions in some people. Antioxidant and anti-inflammatory foods: tart, cherries, berries, dark chocolate, high cocoa content, and vibrant veggies to aid in managing exercise-induced soreness and promoting vascular health. Micronutrients for healing: zinc found in pumpkin seeds, vitamin E present in sunflower seeds and nuts, and vitamin C located in citrus fruits and peppers facilitate tissue repair and collagen formation. Pre-workout snack: whole grain bread with peanut butter and dried cherries or a small banana accompanied by a handful of almonds harmonizes carbohydrates for energy with moderate protein and anti-inflammatory advantages. The glute bridge with intentional core engagement, restoring hip extension and lumbopelvic coordination. Justification and neuromuscular advantages. Sedentary habits and extended periods of sitting often lead to underactivation of the gluteal muscles, resulting in gluteal amnesia, which necessitates compensation mechanisms from the hamstrings and lumbar extensors. The glute bridge with deliberate core activation retrains the central nervous system to begin hip extension from the glutes, while stabilizing the lumbopelvic complex via the co-activation of deep core muscles, namely the transverse abdominis and pelvic floor. This integration minimizes compensatory lumbar motion, lowers the likelihood of low back pain, and enhances the efficiency of functional activities such as standing, stair climbing, and walking. Enhanced hip extension also increases step length and gait propulsion, resulting in faster, more stable walking. Principal musculature and biomechanics. Gluteus maximus, principal muscle for hip extension and external rotation. The gluteus medius and minimus serve as lateral stabilizers of the pelvis, crucial for unilateral stance and ambulation. Hamstrings, synergistic muscles that aid in hip extension. Excessive activation of the hamstrings may suggest underutilization of the glutes. The transverse abdominis and pelvic floor serve as deep stabilizers, establishing a firm foundation for hip movement. Spinal erectors maintain a neutral spinal alignment during the bridge exercise. Sequential execution 1. Assume a supine posture on a solid surface, with knees, flexed feet aligned at hip width, and heels placed within fingertip reach for comfortable engagement throughout the lift. 2. Arms positioned beside the body, palms facing downward. Inhale deeply, using diaphragmatic breathing. During exhalation, gradually retract the navel towards the spine to engage the transverse abdominis subtly, not aggressively. Envision contracting the anterior torso instead of exerting excessive tension. 3. Firmly contract the gluteal muscles, apply pressure through the heels, and elevate the hips until the body aligns in a straight line from shoulders to knees. Refrain from excessive arching of the lumbar region. 4. Maintain the abdominal engagement and glute contraction for 2 to 5 seconds, then gradually drop the pelvis back to the floor in a controlled way. 5. Commence with 2 sets of 6 to 8 controlled repetitions, 3 times weekly, and advance to 3 sets of 10 to 15 as motor control and strength improve. Progressions and variations. Incorporate a resistance band positioned above the knees to promote lateral gluteus medius activation by exerting outward pressure throughout the lift. Implement a single-leg bridge after achieving bilateral control to enhance unilateral load and test pelvic stability. The bridge position is maintained for extended periods, 15 to 30 seconds, to highlight endurance and postural stability. Marching bridges alternating knee elevations while maintaining the elevated posture to improve dynamic stability. Elevated foot bridges, feet on steps, or a tiny box enhance range and difficulty. Perceptual feedback and anticipated feelings, normal intense contraction in the gluteal muscles, and little activation in the lower abdominal region. Moderate fatigue in the hamstrings as secondary contributors may be experienced at higher repetitions. Problem indicators, hamstring cramps, clenching, or low back discomfort indicate excessive dependence on hamstrings or lumbar extension. Reposition feet nearer to buttocks, reduce pace, and emphasize a controlled glute contraction prior to lifting. Frequent technical errors and rectifying prompts. Lumbar extension lifting instruct to lift with hips not back. A tactile cue is beneficial position, a hand under the lumbar spine to detect arching and limit the range to achieve a neutral spine. To address knees falling inward or splaying outward, use a band around the knees or place a small cushion between them to promote alignment and activate the gluteus medius. Begin with the hamstrings position, the feet nearer to the buttocks, emphasize posterior pelvic tilt, and deliberately activate the glutes prior to lifting. A shorter range with enhanced concentration may be preferable in the outset. Alterations in clinical considerations, recent lumbar disc herniation or acute low back pathology, seek physical therapy supervision prior to doing bridges. Adjustments or alternate core activation techniques may be necessary. In cases of severe osteoporosis, refrain from quick or violent movements. Execute calm, controlled lifts and seek guidance from a doctor on permissible ranges and supports to mitigate the danger of compression fractures. Postoperative hip, adhere to surgeon-therapist limitations about hip flexion and rotation. Modified or aided bridges may be required. Nutrition to enhance posterior chain and core training. Protein-sufficient consumption to facilitate brain and muscle recovery. Include 20-30 grams of high-quality protein post-exercise when possible. Anti-inflammatory lipids, omega-3 fatty acids derived from fatty fish walnuts and flax seeds, may alleviate joint and soft tissue pain and facilitate healing. B vitamins facilitate energy metabolism and neurological function found in eggs, fortified cereals, lean meats, and nutritional yeast. Nutrients that promote bone health include calcium found in leafy greens, fortified plant milks, and tofu vitamin D obtained from sunshine-fortified foods and recommended supplements, and vitamin K2 present in fermented foods, all of which contribute to skeletal integrity, essential for safe mobility. Evaluate clinical supplements. Creatine supplementation demonstrates efficacy in enhancing muscle growth and function in older individuals when integrated with resistance exercise. See a healthcare physician prior to initiation. Incorporating the 3 workouts into a pragmatic regimen. Guiding principles for advancement. Progressive overload incrementally enhance intensity by extending hold duration, augmenting repetition sets, range of motion, including unilateral variations, modifying tempo and increasing external load as feasible. Frequency and distribution strive for 3 to 4 concentrated sessions weekly, or allocate shorter high-quality sessions, 10-20 minutes across additional days, to ensure consistency and establish a habit. Emphasize quality over quantity emphasis, deliberate controlled motions with concentrated neuromuscular signals instead than hastily executing large quantities with inadequate form. Recovery includes sleep-appropriate protein distribution, hydration, and mild exercise on rest days, such as walking and moderate mobility to facilitate adaptability. Reduce intensity during episodes of sickness or inadequate sleep. Illustrative 12-week progression. Weeks 1-2. Fundamental. Wall sit 3 sets of 10 to 20 seconds 3 times per week. Calf raises 2 sets of 10 repetitions 3 times per week. Glute bridges 2 sets of 6 to 8 repetitions 3 times per week. Emphasis technique, respiration, and neuromotor acclimatization. Maintain a deliberate pace and accentuate signals. Weeks 3 to 6. Development. Wall sit. 3 sets of 30-45 seconds 3-4 times a week. Calf raises 3 sets of 12 to 15 repetitions. Include 1 exercise weekly with gradual eccentric movements 3-4 seconds for lowering. Glute bridges 3 sets of 10-12 repetitions. Include a band above the knees. When proficient, objective augment volume. Include resistance bands for stability in the frontal plane and lateral control. Weeks 7 to 10. Challenge. Wall sit 3 sets of 60 seconds, perhaps using partial dynamic pulses, 10-15 tiny pulses throughout the hold to include minor concentric features. Calf raises 3 sets of 15 to 20 repetitions. Include single leg sets 1-2 times per week as tolerated, and combined step deficit eccentric exercises. Glute bridges 3 sets of 12 to 15 repetitions. Include single leg bridges or marching bridges. Increase band resistance. Emphasis unilateral strength, dynamic stability, and tendon loading methodologies. Weeks 11 to 12. Consolidation and functional translation. Sustain or marginally elevate load while including functional transfer exercises, including controlled step-ups, sit-to-stand practice lateral step-downs, and brief supervised ambulation emphasizing push-off mechanics, 2-3 strength sessions, and 1 functional session weekly. Concentrate on translating improvements into daily activities, simulating stair ascent and standing duration tasks, and evaluating performance metrics. Illustrative weekly session sample. 20 to 25 minutes. Warm-up. 5 to 8 minutes. March in situ. Do ankle circumductions, execute hip mobilizations, conduct light knee flexions, and complete 1 to 2 dynamic step-ups. Primary segment, 12-15 minutes. Wall sit 3 sets at goal duration with 45-60 seconds of rest. Calf raises 3 sets of 12-15 repetitions with a gentle 3 to 4 second descent on the last set. Glute bridges 3 sets of 10-12 repetitions, including a resistance band for 1 set. Cool down 3 to 5 minutes, mild stretches for the hamstrings, quadriceps, and calves, diaphragmatic breathing, and short soft tissue rolling if comfortable. Examples of adaptable sessions based on capability. Novice limited tolerance or balancing issues, 10 to 12 minutes in total. Wall sits 3 sets of 10 seconds in a sitting or shallow position. Seated calf raises 2 sets of 12 repetitions. Bridges 2x6 limited range. Utilize chair support. Intermediate proficient in fundamental movements 20 minutes. Perform wall sits for 3 sets of 45 seconds each. Calf raises 3 sets of 15 repetitions bilateral and occasional unilateral. Bridges 3 sets of 12 with resistance band. Advanced optimal balance and strength, 25 to 30 minutes. Perform wall sits for 3 sets of 90 seconds or hold with pulses. Execute calf raises using step deficits and single leg sets. Conduct single leg bridges and marching bridges, and complete functional step-ups with added weight. Assessing progress and diagnosing issues. Objective assessments reevaluate tug-timed up-and-go 30-second sit-to-stand single-leg stance duration and timed wall sit every 4 weeks. Timed up-and-go, tug scores above around 12 to 13. 5 seconds are often correlated with an elevated risk of falls. This should be interpreted within the context of individual health and normative standards. Supplementary metrics monitor maximum repetitions of single-leg calf raises, durations of single-leg bridge holds, or maximal isometric wall sit periods as indicators of performance. Subjective assessments monitor the simplicity of everyday activities, e.g., stair navigation, standing perceived effort, RPE scale 0-10, and discomfort or soreness. Contemplate using a basic diary or application to record sessions. Plateaus alter stimuli. Tempo variations, unilateral exercises, guarantee sufficient protein intake and sleep. Reassess recovery methods and evaluate for persistent discomfort or nutritional deficiencies. Strategies for adherence and behavioral recommendations. Habit stacking, associate exercise with established routines, post-morning coffee, post-toothbrushing or immediately after dressing. Brief regular sessions, 10 to 15 minutes daily, may provide superior adherence compared to lengthier occasional exercises. Numerous micro-sessions, 5 to 10 minutes distributed throughout the day, might be efficacious. Accountability, engage in exercise with a spouse caregiver, or utilize a tracking application journal that includes reminders and visible success indicators. Prominent cues, position an exercise mat, resistance band, or chair in a conspicuous location to prompt activity. Acknowledge little achievements, enhancements in functional assessments. More confidence on stairs or less challenges with a task serve as encouraging milestones. Incentivize consistency instead of perfection. Particular clinical considerations: osteoarthritis of the knee, hip, minimize depth and pain-inducing ranges. Isometric exercises and partial ranges are permissible and advantageous when pain is managed. Explore adjunct therapy like weight control, orthotics, or brace use, and seek physician consultation for personalized strategies. Individuals with ischemic heart disease, arrhythmias, or uncontrolled hypertension must get medical clearance and adhere to a regimen of graded exertion. Observe signs like chest constriction, excessive dyspnea, or fainting. Exercise care while engaging in isometric activities since they may temporarily elevate blood pressure. Diabetes with neuropathy. Maintain foot health, do frequent inspections of skin and nails, guarantee safe surfaces, and contemplate sitting progressions until protective feeling is sufficient. Recent surgery or fractures, adhere to rehabilitation guidelines and the instructions of the surgeon-therapist about the permissible range load and time for beginning. Cognitive impairment, streamline cues, provide demonstration and tactile instruction, and include caregivers to guarantee safety and consistency. When to seek professional counsel. Onset or exacerbation of acute discomfort during physical activity, edema, or neurological manifestations, paresthesia, advancing weakening. Inability to properly execute the exercises owing to balance issues or significant pain, consult a professional physical therapist for personalized evaluation and advancement. Intricate medical histories, cardiac disorders, unmanaged psychological issues, or many medical comorbidities necessitate meticulous medical supervision and customized advancement. Prevalent misconceptions and elucidations. Heavy lifting is essential for strength enhancement, neuromuscular adaptations, and endurance improvements from body weight. Isometric and concentric eccentric exercises provide significant functional benefits, particularly in deconditioned older persons. Progressive overload does not need substantial external weights to produce functional adaptations in the first stages. Soreness is essential for advancement. Moderate discomfort may arise, but pain is not necessary. Steady advancement without excessive discomfort signifies efficient training. Resistance training will lead to excessive muscle growth. Hormonal and age-related variables render significant hypertrophy improbable without high-volume, high-load exercise. In this context, the major objectives are functional strength balance and neuromuscular control. Integrating functional transfer and practical advantages. Engaging in wall sits, calf raises, and glute bridges with a focus on technique and progression enhances the neurological system alongside muscular development. Timing, sequencing, and force production are refined. Both clinically and anecdotally, Older persons often see improvements within days to weeks, including enhanced gait stability, more comfort in rising from chairs, less stiffness, and heightened confidence. Initial successes bolster compliance and facilitate advancement towards elevated functional objectives, enhanced stair climbing, safety extended walking durations, diminished dependence on assistive equipment, and lowered fall risk. Functional exercises, such as step-ups, sit-to-stand repetitions, and simulated stair climbing, should be used after foundational capability is achieved to enhance applicability to everyday tasks. Concluding reminders: consistency and quality surpass sporadic intensity. Consistent concentrated exercise of 15 to 20 minutes daily yields far greater long-term advantages than sporadic intense efforts. Attend to your body's signals. Differentiate between anticipated muscle exertion and cautionary pain indicators. If uncertain, decrease intensity and get a professional assessment. Nutrition, sleep, and hydration are crucial components of exercise-induced adaptation. Strive to achieve protein objectives, maintain fluid equilibrium, and include anti-inflammatory, nutrient-rich meals. Individuals with pre-existing medical issues should seek advice from a healthcare expert or qualified physical therapist prior to beginning a new program to guarantee personalized safety and optimum advancements. Incremental, consistent enhancements accumulate. Even little extensions in hold duration, an extra repetition, or a reduced rest period signify substantial advancement and foster drive. By dedicating continuous time and focus to these specific low-cost workouts with prudent diet and recuperation, persons aged 50 and over may markedly enhance lower body strength and neuromuscular control. This program transcends ordinary muscular training. It represents an investment in enhanced independence, less fall risk, increased circulation, and a significant improvement in the capacity to engage in everyday activities that promote an active, full life. Thank you for watching the video. Please let us know your thoughts, and goodbye for now.